questions. This is an interactive session. I'll answer all your questions. We have another 10 minutes. Yeah, 10, 15 minutes until 8:15 IST. Can I walk with a sprained knee? No. You should use a support, see your doctor, get a brace, and do the needful. If the sprained knee, the pain doesn't come down, then you'll need other modes like MRI, and everything comes under sports medicine. This is another area where you injure a ligament, you tear a ligament, and then you neglect it, or you look at other forms of therapy instead of going for surgery to reconstruct or replace something, and then you end up as 18 to 24 months post this injury, and then your joint. There's something called biomechanics where the knee works in harmony. There are a lot of ligaments, soft tissues, the menisci, the weight of the body, the center of gravity, everything works in harmony, and the movement of the joint on both surfaces. Rotations happen at both the thigh and the leg bone. If one of the ligaments, like the anterior cruciate ligament or medial meniscus, or if you have a little lax medial collateral ligament, and it is not attended to or treated properly, because in this area we have sports medicine that caters to all injuries of the knee and any joint for that matter. So if you neglect that, in 2 to 3 years, you will start having degenerative changes. We call it as osteoarthritis. And if you keep walking on that, bearing the pain, buying anti-inflammatories and medicines at the pharmacy yourself, and not doing the right bracing and exercises, physiotherapy after sorting out a medical opinion, then you're at a bigger problem. Does a torn Achilles tendon hurt? Definitely, unless it's a chronic tear and you're used to it. Can one run a mini marathon with a replaced knee? Definitely you can run a mini marathon, depends on what age you are and how heavy you are. If you're a regular runner, Kiran, if you're a regular runner, I don't think, and if you've been exercising good enough, I don't think you'll need a knee replacement. I've seen a lot of x-rays where the x-ray looks so bad, degenerated, but the patient is so nice, and he's not having much pain, a significant pain, because if we ask him to do the pain scale therapy, like, if you ask him, he will just say this, 3, you see? There's a Warren Baker pain scale, so he's smiling. So this is his level of pain. Would you want me to do a surgery on him? But some people come here, for 2 years they've been like this, or for 2 years they've been like this, and when they come to you, they're like this. Is the time to attend to them. So a person who runs marathon, a mason, I told you, masons and farmers, agriculturists, they have 3.7 to 4% increased incidence of osteoarthritis, and most of them, they're very strong. The muscles are very strong. They have been very active in their teenage, middle age, and now when they come to you with a deformed bow-legged or whatever, most of them are not obese. They're very thin and they're very lanky, and they're very tough. We give them brace and supportive and exercises. Most of them do very well. Now, in case you've been an old army man, you've retired because of an injury and you've had this, you can't perform your duties, you're not able to walk a mile, your pain is increased at night, and we have a scale called the Oxford knee score, where we evaluate a patient based on his activity, sitting and getting up after lunch, not able to ascend or descend stairs without support, doesn't go out for active shopping or independently, all these things. Then we have to do a knee replacement. A mini marathon is 21.195, and I wish that when you undergo a knee replacement, you don't have to run 20 kilometers and wear out the poly that is inside this. You shouldn't be wearing out. You get a cataract operation, or you get a bypass, or you get a knee replacement, you have to take good care of it. I don't think you should be running mini marathons. You should be running away from bad things, that's all. Yeah. Now, some more questions. Is a cracking sound from knee when climbing stairs? Mahesh is asking. Needs to be treated even though there is no pain. It means you have to strengthen your muscles. You have to strengthen your muscles. They are a little weak. So that is the meaning. And probably a little bit of the lubricating fluid is coming down. There are many ways to increase your lubricating fluid, or at least kind of make your joint smooth. One is by losing weight. Second is, it's believed that curcumin from turmeric and even pipalongum pepper and a good diet that is rich in omega-3 fatty acids helps us to increase our lubrication in the joints. So this has been there, but there's not a significant study to prove that this is the treatment for osteoarthritis, though they are very handy and they are supposed to be done by everybody at any age to prevent faster progression of osteoarthritis. If I see an athlete with a very, if I get his MRI, if he's got a subtle cartilage thinning, but he's very healthy, this is the diet. You get him on, these kind of nuts and fruits and vitamin D supplements, vitamin C. Then you put him on all this pepper and turmeric. As you know, I don't have to mention, they have had a long association with us for the last 9 months because of COVID. So I think it's time to continue that. Natural foodstuffs without any preservative. High trans fat, refined sugars should be avoided. Without preservatives, yes. Is age-related degenerative OA still in the stage of osteophytes? Can something be done before it gets worse? Well, now actually the incidence of younger arthritis, people who are below 45, is increasing. So there is a dilemma how we go about these things. So that's why these stem cell therapies, oats like cartilage chondrocyte transplants, and other things, bracing with new technology, and stem cell therapies are all coming into vogue. But then before the osteophytes come, see, certain forms of arthritis don't get osteophytes. Osteophytes is nothing but bone spurs. If you have a very smooth joint, I'm running out of space on just give me a minute. This is a normal joint. Now this is a joint with osteophytes. Rough and reduced joint space. So these are osteophytes. These are degenerative changes because of excess loading. So there is no way that you can reduce osteophytes, but it's just you can slow down the osteophytes by exercising and building up muscles and soft tissues around your joint. Now, in certain forms of arthritis, mainly the inflammatory arthritis, the osteophytes are very less. Doesn't mean that it's not arthritic, but in rheumatoid, you will never get as many osteophytes as you get in osteoarthritis, primary osteoarthritis. What is a shin splint? I think it's a little irrelevant to the topic today, but shin splint is nothing but stress fracture of the tibia. So that will be coming up later in this one. Thank you. Can osteoarthritic patients climb the stairs, Ms. Veena? So these are all very common questions being asked to us. If necessary, when you have severe pain, but if you're the only one in the house, if you have to go and dry your clothes up, you got to attend to somebody on top, you have to do it. But on the other hand, if you can avoid ascending stairs, ground activities, squatting, sitting cross-legged, kneeling and praying, all this should be avoided. Whatever puts load on the knee until you get your knee ready partly or near normal. That is by reducing your weight, doing physiotherapy, doing the appropriate follow-ups, getting the appropriate follow-ups with your doctor, orthopod, and the physiotherapist. It is imperative that you don't keep damaging your knee by going up and down. In the end, we have two problems. One is loss of function, that is called disability. And the second is pain. It's like a wheel of a cycle. If you have pain, and then when the pain comes down, your function increases. If your function increases, your pain comes down. The function part is the physiotherapy. The pain part is what you do to yourself to reduce your load on the knee. Physiotherapy and your orthopod are very important. So connect them and then get a thorough checkup. While playing outdoor games, knee dislocated sometimes. Some pain and inflammation. It is not a dislocation. Excuse me. Many people come to us with, my knee dislocated. And this is what happened. I went to an Ayurvedic guy and I put it back. Now, knee dislocation is a sense that you feel. It's something you feel that sensation that your knee is dislocated because it is swollen up and you're not able to put a step forward or put your foot forward. That is not dislocation. A knee dislocation is something very grave. You will never be sitting there and then coming after 2 days. If you had your knee dislocated, you can have other multiple, dire consequences, near death, fatal, or even, limb loss also you can have. So these are the knee dislocation. The feeling of instability is what you mean by dislocation. So you can have a meniscal tear, extruded meniscus, you can have a ligament on this side of the knee. Now let me show you. So where's the knee model? Where's the knee model that we took? Alright, so this is clear. So you can have the ACL, anterior cruciate ligament tear, or the meniscal tear, or the medial collateral ligament tear, or you can have a complex where this side, or the outer side of your knee gets affected. This ligament, the lateral collateral ligament, the muscles, the popliteus, and the lateral meniscus also can tear. and this can cause that's called a PLC, and knee injuries that comes under sports injuries. So this is the instability. There's nothing like this. Of course, knee dislocates. You can have no contact between the two joint surfaces. Even in chronic osteoarthritis with deformity, there is a movement, subtle movement, which happens over the years. The tibia keeps moving and subluxating a little bit because of the ligament laxity. But Sangeeta Prabhu, how should a person with knee pain place his knee while lying down? The body will tell you. You will be rotating your hips out, flexing your knees a little bit, and then asking for help. Is there any posture of sleeping to reduce knee pain? There is no specific posture to reduce knee pain. You will sleep only when your knee is at rest. That's a good thing. So, thank you, Ramiredi. So great to be connected with you too. Yeah. What's the strongest indication for a patient to undergo a TKR? What are the limitations of a patient post-TKR? Good question. The strongest indication is when you have seen your mother or father slowing down without any other problems. It's not the age, but it's just the knee or the hip or the ankle. So most commonly the knee. You see them taking their own sweet time to get off the chair after lunch. They have to hold multiple supports. Even you will go to help them. They can't ascend stairs, and they're in the age group. We'd like our patients to be above 55 and 60 to do a total knee replacement. But nowadays the incidence of younger patients coming for total knee replacement is high. And the indications are a very severe arthritis. You should not have there will be no joint space, and the knee looks deformed. You can either have a bow knee or you can have a knock knee, and when you take an x-ray from the hip, the complete center of gravity and center of mechanical axis and anatomical axis is completely changed. So you will not have a proper, the gait of the person changes. Gait means the walking style changes. The time taken for a few steps becomes increasingly more as the months go by. The weather plays a bigger role in them. And it's December, it's going to be December, so they'll be having more pain at night. I'm sure in many places like Bangalore and North, where the weather is just chilling down. So we have a lot of patients who are coming to the doctors with arthritis and deformities, and they're late already. So, and what are the limitations of a post-TKR? I've answered this something, so you should be careful. In a total knee replacement, most of the surgeons can give you good stability and alignment. The problem the next problem is that we should be worried about is general condition like the lungs that should take up the surgery, the heart. So optimization of a patient planning before you take the patient into the operating theatre is the success story of a patient who's going to be very well operated and happy with you for the rest of the life. How much ever you do, average says 19% of the post-total knee replacement patients are unhappy, either because of their mind or either because of the surgery. So most of them. Now, you optimize the patient, you have taken great care to plan for the surgery, you have the right set of implants, you have the backup happening, and you're getting me? Yeah, you have the backup happening, you have the right people doing it, you have the right force in the operating theatre, atmosphere, everything happening. But still the patient can say that I still have a pain, I still have this, I still have that. Are we getting it right? We're getting it right? Okay. So the other thing so this is a very important thing. So pre-planning and the patient is very scared of pain. So he'll ask you, he or she will ask you, I want general anesthesia, I don't want to know anything, I shouldn't be having pain. So looking at social media, listening from other people, they start getting worried. So the pain therapy starts from the time when you start seeing the patient in the OPD, and then until the patient gets discharged and beyond, up to 6 months. Now, post-operatively, we can have infection. This is the most dreaded complication of a total knee replacement. If I'm talking about the knee locally, there are other things which happen generally also. You can have so many things, but we'll focus on the infection for now. So, without an immunocompromised state like diabetes or anything, the incidence of infection is about 0.5 to 1%. With diabetics, it's about 2.5 to a little more. So you have to make sure that you rule out all sources of infection, especially in the aging ladies, menopausal ladies. You will have yeast infection. They will have uterine prolapse. So they'll spurt some urine when they cough, when they sneeze. That can wet their inner garments, stay there moist, getting all kinds of infection, yeast and bacterial. Then dental infections. Most of them will be having bad teeth. You'll have to rule out dental infections, do the needful, get a dental consultation done well before surgery. And if they have their braces or they have their dentures, attend to that. Then chest is one thing. Elderly people have very poor cough reflexes. They might have chronic tonsillitis, or they might have poor chest compliance, which may lead to stagnant secretions. You'll have to take care of all that. So an important thing is you get a physician, you get a cardiologist, you get a gynecologist, you get a dental guy, and you get anything. Suppose you have an endocrine disorder, rule that out, and then put patient on the table after doing all these checkups. Post-operative, you'll have to get your reports every 6 to 12 hours, follow up the patient. You make sure your stability during the operation is fine, double check it, and follow up the patient. First 14 days, the patient will have some pain and inflammation. Of course, we have done this. We have done a surgery, so there will be some inflammation caused by the doctor and surgery. Cement is another thing that can cause inflammation. So you have to be careful about all these things. We have a lot of pain control measures which start from consoling the patient, being a little compassionate, telling them what the surgery is going to be and how your admission goes on, and then talking to the patient, asking them to write down any question that they have to ask. When they're in doubt, they will only go home, they forget half of your explanation, they'll go home and then they'll come back with new doubts. So you ask them to write down. Being patient with the patient it works. And then having a proper conditioning of the night before surgery, the previous night before surgery, intraoperative cocktails, patches, buprenorphine patches, other medicines for intravenous. The anesthetist will take care of the epidural analgesia also. All these work together, and plus a little bit of vocal analgesia also. Yeah. Great. The next question is we have doctor, you're explaining everything in detail. Thank you. Welcome. Once the operation done is not success, can we do any rectification or restore? Mr. Taha. Success means that the patient, when he comes to the doctor, he wants only pain relief. He doesn't care a damn what you do. But for the surgeon, it's a restoration of alignment. So you'll have to plan the surgery properly. And if you do the alignment well, taking care that we don't have any source of infection coming in because of ill preparation of the patient or intraoperative, we are not taking so much care, or there's a gap in between, antibiotic, something like that. So this can be a problem. So infection is the second one. First is instability. My boss always told me, if your patient's knee fails in the first 3 years, it's the technique that matters. So this is the problem. Second, if the patient's knee fails in 7 to 10 years, the technology was the problem. So it's not the technology nowadays, it's the technique mostly, and most surgeons are very adept, and you have to be optimized for your health condition, and the knee has to be understood very well, and then the surgeon will do it for you. And if the knee has failed because you have had a fall, unfortunately you have had an infection, the doctor is not going to cause infection to you deliberately. You have had an infection because you have not controlled your diabetes, or there was a leakage from the catheter, or home care was poor, or there was some infection somewhere in the body which was never detected, and all these things. This success is going to be very devastating. So these are things that are preventable. You should be double sure, the doctor and the patient should be double sure before getting on to the surgery. Now, in case your knee fails, you had loosening of the implant without infection, loosening of the implant with infection. The treatment is different. It's a very complicated topic. We'll talk about it in the coming discussions on a different day. So, just want to know if enchondroma of distal femur will cause any issues later. If you are having an enchondroma that is not causing any impingement on your nerve or on your vessel, and if you're liking the feel of touching it now and then, it's fine. Otherwise, get it removed. It's okay. Excised. Yeah. Get a biopsy done. It's good to get it done if it's more than 5 centimeters. Thank you, everybody, for the comments. And we have just one last question to answer. So, yeah, so we'll sum up. So this is pain is one of the most common symptom with with which patient comes to the doctor. So osteoarthritis is very common, but still poorly understood and badly misunderstood by the people around, because they're confused with the social media, googling down, looking at their symptoms. Out of 2 symptoms out of 15 symptoms on Google or YouTube doesn't mean that your diagnosis is right on Google. And sort out and seek medical help when you really require. And there are a lot of people who have the facility, there are a lot of hospitals who have the facility to do all kinds of invasive and non-invasive, surgical, non-surgical, and now the drug list in pharmacology has improved, and a wise person will also include the physiotherapy, lifestyle modification, some amount of naturopathy. If you ask me, even acupressure and reflexology has worked a great deal in certain patients. It's good to try these out, because if it works, it's good. If it doesn't, you've not lost anything. So this is a good thing. Get yourself eating natural diet, a lot of fruits, avoid junk and trans fat, refined sugars, and eat on time. Eat on time. That's the most important thing. Control your sugar. Seek your surgeon's, I wouldn't say surgeon, an orthopedic doctor's help, and then kind of get yourself treated. Because if you neglect one stage to the other, costs you a lot, and it is not reversible, mind you. Thank you, everybody.